Greetings from Indian Journal of Anaesthesia. I, Dr. Raniki Sharma, will be presenting an article published in the June 2024 issue of Indian Journal of Anaesthesia. It is titled Comparing the Posture and Comfort of Anesthesiologists During Laryngoscopy and Tracheal Intubation in the Head Elevated Laryngoscopy Position in Supine Position and with a 25-degree backup, a randomized clinical crossover trial. We all know that proper patient positioning is crucial for successful glottic visualization and tracheal intubation during anesthesia. The head elevated laryngoscopy position has been found to be superior to the traditional sniffing position in facilitating laryngoscopy and tracheal intubation. Combining this position with a 25-degree backup further improves the glottic visualization, but it is not commonly used due to concerns about discomfort and abnormal posturing among anesthesiologists. So this study aimed to assess the posture and ergonomics of anesthesiologists during tracheal intubation using the head elevated laryngoscopy position with a 25-degree backup versus the supine position. The primary objective was to measure and compare the posture adopted by anesthesiologists by measuring various angles of neck flexion, wrist angle deviation, arm exertion, lower back flexion in these two positions. The secondary objective was comparison of the anesthesiologist's posture and comfort by a 4-point Likert scale, the Cormack-Lehane grade, the time to intubation, and hemodynamic and complications during laryngoscopy and intubation between the two groups. So institutional ethical committee approval was taken and the trial was registered in Clinical Trials Registry of India. It was a randomized controlled trial that included adults 18 to 70 years of age with ASA grade of 1 and 2 requiring endotracheal intubation with normal airways, that is mouth opening more than 3 cm, modified Malampatti class of 1 to 2, complete range of neck movements and positive upper lip bite test. The patients with anticipated difficult airway, patients requiring emergency surgery, patients with hemodynamic instability, risk of aspiration or BMI more than 35 kg per meter square were excluded from the study. This study also defined the operator who would be doing laryngoscopy had to have an experience of at least 5 laryngoscopies in the 25-degree backup head elevated laryngoscopy position. So grouping was done by permuted block randomization with a block size of 4. 12 anesthesiologists in total participated in the study. Each anesthesiologist performed study on 4 patients as per permuted block randomization, and patients were allotted into 2 groups depending upon the position that they were intubated in, that is the backup position, 25-degree backup position, which is group B, and the group S, that was the supine position. But all patients underwent laryngoscopy in both the position, followed by intubation according to the group allocated. So all patients were pre-oxygenated with 100% oxygen, and after giving anxiolytics midazolam, and patients were induced with fentanyl, propofol, and vecuronium. So the 2 positions were the supine position with the head elevated laryngoscopy position. And in this figure, we can see the 25-degree backup head elevated laryngoscopy position, which is made by flexing the OT table to 25 degree using a remote with the angle identifier app in the mobile to align the patient's tragus to the sternal notch. And if it was not possible with the flexing of the OT table, then cushions were placed beneath the patient's head to facilitate the alignment. In both the positions, the patient's head was at the level of the intubator's xiphisternum. After that, during intubation, the joint flexion was measured with angles in the photo app. The photo was taken while performing the procedure, and these were the photos taken, the wrist angles taken, wrist deviation angle, elbow flexion, neck flexion, and lower back flexion. If intubation was not successful in the first attempt, then the patient was repositioned. If intubation failed at second attempt, then unanticipated difficult airway was declared and institutional protocol was followed. So there were two groups. In the group B, first the laryngoscopy was done in the supine position, followed by intubation in the 25-degree backup position. In group S, laryngoscopy was done in the 25-degree backup position, followed by intubation in the supine position. So the primary outcome was to measure and compare the posture adopted by anesthesiologists by measuring the angles of neck flexion, wrist angle deviation, arm angle exertion, and lower back flexion while performing the tracheal intubation in both the positions. The secondary outcomes were anesthesiologist posture and comfort by a 4-point Likert scale, the CL grade, time to intubation, hemodynamics and complications during laryngoscopy and intubation between the two groups. The sample size was based on a study which stated that in supine position, the anesthesiologist's leg flexion was 54 plus minus 13 degree. So the authors hypothesized that the 25-degree backup position would be associated with lesser neck flexion. To find a reduction of 25% neck flexion in this 25-degree backup position with a beta of 95% and alpha of 0.05, total 22 patients were needed in each group. Taking the dropout rate as 10%, the sample size came out to be 24 patients per group. Statistics was done by JASP team 2019 version 0.11. Parametric data were expressed as mean, non-parametric data were expressed as numbers and percentages. Students' t-test was used to compare the angle of neck, arms, back flexion, laryngoscopy time, intubation time, and hemodynamics. Chi-square of Fisher's exact test was used for anesthesiologist comfort and CL grade, and P less than 0.05 were considered significant. So in the results, we can see that the neck flexion, wrist deviation, elbow flexion, lower back flexion, the angles of this did not differ between the two groups during laryngoscopy and intubation. The anesthesiologist's comfort during laryngoscopy and intubation was also statistically insignificant, but the CL grade was better in the backup position than the supine position. Significantly better. Similarly, the hemodynamic parameters in terms of heart rate and mean arterial pressure were similar between the two groups during laryngoscopy and intubation. So, this study found no significant difference in the anesthesiologist's posture or comfort during laryngoscopy and intubation between the supine position and the 25-degree backup head elevated laryngoscopy position. However, the 25-degree backup head elevated laryngoscopy position provided significantly better glottic views. We all know that proper patient positioning is crucial for optimal glottic visualization, and various postures adopted by anesthesiologists may impact long-term joint health. So this study highlighted the importance of ergonomics in minimizing the risk of injury to anesthesiologists and ensuring optimal patient care. The 25-degree backup position improved the CL grade of visualization, aligning the airway axis, requiring less force for tongue displacement. The strengths of this study was that it employed a crossover design, recruited experienced anesthesiologists, and standardized the OT table height. Limitations included a small sample size, single center study design, potentially limiting generalizability, and the studies focus on patients with easy airways, suggesting caution in applying the findings to difficult airway scenarios. So from this study, we can conclude that in patients with normal airways, posture and comfort of anesthesiologists during laryngoscopy and tracheal intubation is similar between the supine position and the 25-degree backup head elevated laryngoscopy position.